Good afternoon and welcome to the first BRIE Collaborative Implementation webinar. Thanks for joining us today. I'm Amy Etzel, Implementation Manager with the BRIE Collaborative. Before we begin, just a few quick announcements. NCLAC will accept attendance at this webinar session as a CE event. To receive credit, you just need to document your time and submit a short survey. You'll receive an email later today with a link to the survey, along with today's presentation slides and resources. Please remember that if you want a certificate for a credit hour, you must provide either your RN license number or an equivalent ID number and complete the survey by Wednesday, February 5th. If you have any questions about this, please contact NCLAC directly. You all are currently on mute throughout the webinar until we get to the end. Today's speakers would love your participation in a Q&A discussion. If you have any comments or questions, please type them into the chat box, and I'll use them to facilitate a Q&A session at the end of our presentation. Today's speakers declare no affiliation with or financial interest in a commercial organization that could pose a conflict of interest with the educational content of this program. Okay, so that ends our housekeeping portion of today, and now we can get to the real reason why we're all here, which is to talk about behavioral health integration. Today, we will be reviewing and learning about the BRIE Collaborative Behavioral Health Integration Guideline. Ginny Weir, Director of the BRIE Collaborative, will start us off by talking about the background of the BRIE Collaborative itself, and then talk a little bit more about the development process of our guidelines. I will then talk about some of the core components of our Behavioral Health Integration Guideline, and I will review 2 implementation resources that can help clinics begin or build out their behavioral health integration efforts. After that, we'll hear from 2 of our community partners who have some expertise in integration. Sarah Barker is the Assistant Director for Implementation at the University of Washington AIMS Center, and she has over 15 years of experience working with underserved populations. Sarah leads the AIMS Center training and technical assistance efforts with the Accountable Communities of Health in Washington State, and prior to working at the AIMS Center, Sarah spent 10 years at one of the largest FQHCs in Washington State. And in that role, Sarah led chronic disease management, care management, expert, and collaborative care programs across an extensive clinic system. Philip Hawley is our second presenter, and he is the Primary Care Behavioral Health Director for the Yakima Valley Farm Workers Clinic. Philip is a licensed clinical psychologist and has worked in primary care for the past 6 years. Philip manages the Primary Care Behavioral Health Program, consisting of 17 behavioral health centers across Washington and Oregon who provide behavioral health services within the PCBH model of integration. Philip's role as director includes site visits and ongoing support of BHC within the organization, reporting for internal and external stakeholders, supervision for the BHC postdoctoral residents, hiring and onboarding and training of newly hired BHCs, coordination with regional healthcare and behavioral health organizations through subcommittees and work groups, direct patient care through same-day consultation, and provides in-service trainings to assess mental health concerns to staff and the community. Philip is really focused on assisting in complete healthcare for patients. All right, Ginny will now give us a little background on the BRIE Collaborative and our guideline development process.
Thanks, Amy. This is Ginny Weir. Thank you all for being here. We are looking forward to talking about our BRIE Collaborative in general and then our behavioral health recommendations. So in terms of background, we are a public-private group in Washington State. We were formed by our state legislature to improve quality, outcomes, and affordability in healthcare. We have 22 members appointed by our governor, and they represent different healthcare sectors, so employers, hospitals, health plans, public purchasers, clinician organizations, and then quality improvement organizations. And our members will choose healthcare topics every year that show variation in delivery and outcomes, that are used inappropriately or too often, that are not used enough, that have a patient safety issue, or really that have an equity issue, that our community wants to make a change in but really doesn't have another mechanism for doing so. Next slide. So our recommendations are based in clinical evidence, and we have this reproducible process for developing our Our work groups are made up of mostly clinicians, but also administrative experts and patients. And this collection of volunteers will meet for about 9 to 12 months. It's really developed from the ground up by the clinical community for the clinical community. And it's not the state or any other body telling anyone what to do, but really a collaborative process of looking at these best practices. So in these work groups, we review published literature, guidelines from specialty societies, the work of other quality improvement organizations, national entities, and what's working and what's not working in systems across our state. There's really a balance between standardization and individualized medicine, and we really try to strike that balance in a logical way with these topics. And we do have to work to make our recommendations attractive to clinicians, payers, and to patients. And of course, collaboration always means compromise. So our primary implementation pathway is through the Healthcare Authority. They are meant to incorporate our recommendations into purchasing contracts. And outside of this public purchasing space, we cannot mandate adoption and we cannot set healthcare prices. So we do a lot of convening, outreach, and education. Next slide. This is our start in 2011. We've worked on a wide variety of topics, and you can see them listed here, starting with obstetrics, looking at appropriate C-sections, and then moving on to this variety of topics, looking at low back pain, end-of-life care, opioid prescribing. We really work to be responsive to topics identified by our community and by our members. And you can see our largest topic areas are around chronic and acute pain, around behavioral health, around surgical procedures, so especially bundled payment models and warranties. And so behavioral health has been one of our primary focus areas since our work group's development of evidence-based standards in 2016. And we've also developed specific pathways for suicide care, for screening, brief intervention, and referral to treatment, and for opioid use disorder treatment. And many of the elements that we talk about within behavioral health integration, like team-based care, really apply across a lot of these topic areas. And many of our members have said that if you can do behavioral health integration right, you can really do anything right, from high-quality palliative care to caring for those with Alzheimer's, because you have these necessary structural components. So this is a big topic for us, and we're very enthusiastic about our implementation work. I will turn it back over to Amy.
Great, thank you so much for that background, Ginny. Okay, so one of the biggest and best guidelines, in my completely unbiased opinion, that the BRI has produced is the Behavioral Health Integration Guideline, adopted in March 2017. The work group identified 8 key elements of integrating behavioral health into primary care setting, utilizing knowledge and information from national and local experts. So we will walk through each of these elements today and then talk a little bit about some action steps that primary care settings can take toward integration. So element number 1 focuses on care teams. True integration really can't happen without a team-based approach between primary care and behavioral health providers. And in order for this to happen, a first kind of foundational step really is an overall commitment within the practice and among leadership to embrace this goal of integrated care. That's really the first step. None of this will work unless everyone is on board. After this, each player of the care team really needs to have a clear idea of what role they have in that overall care team. We often talk about clinicians and support staff wearing many hats, which can lead to duplication of efforts, or on the flip side, some aspects of patient care falling through the cracks. So when everyone's roles are defined, we can be sure that nothing is missed for the patient. Another aspect of integrated care teams is shared workflows. We also talk a lot about siloed care, that primary care and behavioral health care are separated. In true integrated care, patients see their primary care and behavioral health providers as being part of one team and a sort of a cohesive and united team. So in order for this to happen, the care team really needs to be in regular contact with each other about the patient that they share, and we recommend ongoing team huddles, pre-visit planning with both primary care and behavioral health teams involved as much as time allows. The second element of behavioral health integration is patient access to behavioral health as a routine part of care. We really want clinic staff to have a clearly defined process for assisting patients with accessing behavioral health services. Best case scenario, this means there are behavioral health providers on site and that these providers are available for warm handoff that day. Obviously, time, money, and space don't always allow for this. So at a minimum, we recommend a care plan is developed with the patient that day so that the patient and the care team are aware of the next steps and that a referral is in place. We also think about removing as many barriers as possible for this patient, especially in the first month of care as we're trying to establish behavioral health services into this patient's overall care. So take the time to ensure that the patient's needs are being met in terms of how they prefer to receive these behavioral health services, whether that's by phone, in person, or virtually. The third element that the group identified is accessibility and sharing of patient information. Part of building up this integrated care team is really making sure that all providers and care team members have access to each other's developing care plan for the patient. Really make sure that the chart notes and treatment plans from both primary care and behavioral health side are easily accessible and found in the EHR, and that they're actively working together to develop a shared care plan for the patient. Part of this element is also ensuring that the patient's progress toward treatment goals is being tracked over time in a systematic way. The fourth element is practice access to psychiatric services. This is really important for the primary care provider and their teams to ensure that no one is feeling overwhelmed. The provider should have ongoing consultative access to a psychiatrist to help develop a treatment plan and then adjust treatment as needed if and when the patient's not improving. And then from the referral perspective, when higher levels of care are needed for a patient, staff should have a clear referral pathway and process to assist the patients with accessing this type of care. Sarah's going to talk a little bit later on about this element and then share some resources within Washington that are currently available. The next element that we're going to talk through is operational systems and workflows to support population-based care. This is really about being proactive and identifying these behavioral health needs and then having a structured and defined process in place for staff to do this. Here we mean use of screening tools, using them at regular intervals, and then also having a plan in place for tracking these results and following up as needed based on the results. Practice also tracks patients with target conditions to ensure that patients are engaged and being treated to target. And the sixth element is evidence-based treatments. We really want whatever evidence-based treatments are used within the primary care setting to be adapted for the population, making sure that these are language-appropriate resources or having handouts readily available in various languages, and also making sure that the literacy levels are taken into account as well as age, religion, and culture. That's the first step for this area, to make sure that the patient is on the same page and understanding their treatment. After this, we recommend use of a symptoms rating scale for behavioral health in a way that is systematic and quantifiable, so that every member of the team can easily determine if the patient is improving and can also show the patient how they're progressing. So treatment should include and support self-management as appropriate. The seventh element within the guideline itself is patient involvement in care. This is really making sure that patients feel like a partner in their own care and that their voice is present in the care plan and in that goal development. This should include a conversation about barriers to care. We traditionally talk about social determinants of health in relation to population health, but here what we're kind of getting at is making sure that the care team and the staff engage in these conversations with the patient about what barriers may prevent them from accessing behavioral health or moving forward with their care goals, and building that necessary trust to really dig into what barriers currently exist for the patient, and then making sure that staff has the proper knowledge of their community resources to assist the patient with these barriers. And then finally, our eighth element is data for quality improvement. Here we mean really making sure that system-level data on access to behavioral services as well as patient experience is regularly tracked and collected. And then beyond that, ensuring that there's a quality improvement structure in place to assess this data in order to achieve success in terms of your access goals and other identified outcome standards. Okay, so that was a lot of information, but really, what does this all mean in the real world and how can I use this in my clinic? So I put together some starting ground implementation resources that will be emailed out with our slides later today. The first is this implementation checklist that clinic staff can share with their teams, outlining these elements and the various action items that clinics can take toward implementation, as well as some additional resources that are called out in the full guideline itself. So feel free to talk through, and for your staff that are kind of new to this integration work that this can help give them a background and understanding of what this all means in their everyday practice. I've also put together these core process measures. These are really for clinics to work on, particularly for clinics that are just starting a behavioral health integration effort. These are some areas for you to begin tracking to show progress toward your integration efforts and just give you some ideas of what to start focusing in on working toward implementation of this behavioral health work. All right, and then feel free to reach out to Ginny or I about the BRIE Collaborative itself, the work that we do, or the behavioral health integration guidelines. And with that, we'll now move over to hearing from our local partners and experts, Sarah and Philip, who will provide some further knowledge about behavioral health integration. Sarah's going to talk a little bit about the collaborative care model and its similarities and differences to the BRIE guidelines, as well as share some resources around psychiatric consultative resources around the state. Thank you, Sarah, and welcome.